What if the very immune system that's designed to heal your body is the exact thing destroying it?
Yeah, that's a wild thought, right?
Right. I mean, usually when we think about healing, we picture this straightforward linear process. You get a paper cut, your body sends in the cellular troops, a scab forms, and like a few days later, it's like the injury never happened.
Exactly. The threat is neutralized, the alarm bells turn off, and the surrounding tissue just moves on.
But, that linear process assumes the injury is a single isolated event.
Which is often not the case. The dynamic completely changes when a tissue is forced into this constant underlying state of distress. The alarm bells literally never turn off.
And the troops just end up dismantling the neighborhood they were sent to protect.
It's a huge problem.
It is. And we are diving deep into that exact paradox today, and more importantly, how targeted molecular biology is actually solving it.
Yeah.
We know you are here because you want to understand the intricate machinery of the human body without, getting bogged down in total information overload.
Which is easy to do at this topic, honestly.
Oh, for sure. But our mission today is highly specific and honestly mind-blowing. We are going to unravel the exact biological mechanism of how polynucleotides, which we'll refer to as PNs today, how they can actually heal intimate tissue atrophies.
Yeah, we're focusing specifically on the role of adenosine A2A receptor activation by these polynucleotides.
Right.
It sounds incredibly complex, I know, but it really boils down to how these molecular fragments act as a targeted switch. They're downregulating pro-inflammatory cytokines in intimate tissue and just completely remodeling the cellular environment.
To map out that mechanism, we are synthesizing some really fascinating clinical data with some pretty dense immunological and pharmacological research.
Yeah, we've got a real-world clinical study here tracking 54 women. They were using a polynucleotide-based medical device.
And we've paired that with a deep pharmacological data on purinergic signaling and cytokine modulation. Because we are not just talking about a new intimate moisturizer here.
Not at all.
No, we are exploring a targeted molecular switch that shuts down microscopic fire alarms at a cellular level.
Okay, let's unpack this by establishing the baseline clinical reality. What is actually happening in a condition like vulvovaginal atrophy or VVA?
So to really understand the physical breakdown of VVA, we have to look at the architectural role of estrogen.
Right, the big one.
Yeah, the big one. During a woman's reproductive years, estrogen levels are high, right?
Yeah.
And that creates a very thick, robust vaginal epithelium.
That protective outer layer.
Exactly. It's highly organized. It features these tiny finger-like projections called papillae, and those provide structural integrity and just a massive amount of surface area.
And estrogen also drives the production of glycogen within those cells, right?
It does, yes.
And that glycogen is the crucial food source for the local microbiome. I mean, a healthy vaginal environment completely relies on a robust, dominant population of lactobacilli.
The good bacteria.
Right, the good bacteria that basically feast on the glycogen and produce lactic acid as a byproduct.
Which is so important. It is. That lactic acid keeps the physiological pH nicely acidic, resting right around, 4.0 to 4.5.
And that naturally repels pathogens and infections.
Exactly.
Yeah.
So what causes it to all break down?
Well, the structural collapse happens when estrogen levels plummet. We're talking dropping from premenopausal peaks of around maybe 800 picograms per milliliter down to below 30.
Wow. That is a massive drop.
It's huge. And this happens naturally during menopause, of course, but also medically following certain surgeries or even breast cancer treatments.
And without the estrogen, the glycogen depletes.
Right. The lactobacilli starve and die off.
Which means no lactic acid.
Exactly. Without the lactic acid byproduct, the pH rises and becomes alkaline.
And the physical architecture of the tissue changes just as drastically, right? The protective epithelium thins out significantly.
It loses those finger-like papillae we talked about, so it loses its structural grip.
And the underlying connective tissue, the lamina propria, is suddenly left with almost no padding. The collagen and elastin fibers just begin to degrade.
And the clinical reality for the patient is honestly profound misery. The tissue becomes entirely stripped of its natural elasticity and lubrication.
So we're seeing severe dryness, intense burning.
And dyspareunia, which is frank pain during sexual activity. The mucosa becomes so fragile that even minor everyday friction leads to micro tears, bleeding, and the formation of tiny red spots called petechia.
Right, which indicates superficial hemorrhage. It's awful. If I tried to visualize this mechanical failure, it's like, okay, a healthy vaginal epithelium operates like a damp pump, high-quality kitchen sponge.
Oh, that's a good analogy.
Thanks. You can take pressure, it flexes, it holds moisture, and it bounces back immediately. But VBA turns that lush tissue into a dried-out, brittle, old sponge.
Yeah, exactly.
If you apply pressure to a dry sponge, it doesn't bend or adapt. It cracks. It splinters.
And traditionally, the first-line non-hormonal treatment for this mechanical failure has just been over-the-counter lubricants and moisturizers.
But those treatments just wet the brittle sponge temporarily, you know? They might mask the friction for an hour or two.
But they do absolutely nothing to repair the splintering collagen.
Right, or address the underlying inflammation. If over-the-counter lubricants only act as a temporary Band-Aid, we really have to look at how to actually rebuild that brittle structure.
Which is exactly what this study looked at.
Yes. Researchers tested a novel approach on a group of 54 women dealing with severe atrophy. They utilized a daily medical device known as CE0373 for about 2 to 4 weeks.
And this specific device was a vaginal ovule formulated with highly purified polynucleotides.
Extracted from trout gonads, incredibly.
Yeah, trout gonads.
Correct.
Supported by ingredients like lactic acid and glycerin. And the investigators utilized the Vaginal Health Index, or VHI, to rigorously measure the physiological changes.
The VHI is a strict 5-point clinical scale. It doesn't just rely on the patient saying, oh, hey, I feel better.
Right, it's objective.
A doctor visually and physically scores 5 parameters. Tissue elasticity, fluid volume, vaginal pH, mucosal integrity, and moisture.
A score of 1 means severe atrophy, where the tissue literally bleeds on contact.
And a 5 is a robust, normal mucosa. So moving the needle on this scale requires legitimate tissue regeneration.
And the metrics logged after just a few weeks of polynucleotide application, they reflect a fundamental remodeling of that tissue.
The numbers are wild. Vaginal hydration improved by 59.8%. Secretions increased by 52.7%.
And the deeper tissue elasticity, that collagen matrix in the lamina propria, that improved by 50.9%.
And the painful microtears and superficial petechiae healed by 51.6%.
What's fascinating here is that we are looking at something far beyond temporary lubrication.
Right, a 50% increase in elasticity and structural healing in under a month. That means the tissue is actively repairing its underlying matrix. The brittle sponge is generating new fibers.
Exactly. The sheer magnitude of these VHI improvements forces us to ask how a DNA fragment, which is essentially what a polynucleotide is, how does it communicate with human tissue to initiate this kind of rapid reconstruction?
So to answer that, we have to zoom way, way in, past the gross anatomy of the tissue, down to the level of chemical communication between individual cells. We need to explore the purinergic signaling system.
Yes. This is an incredibly elegant evolutionary mechanism. It basically functions as the body's cellular emergency broadcast network.
Okay, so in a healthy resting state, the extracellular space, the fluid environment sitting outside and between our cells, is relatively quiet.
There are negligible levels of extracellular nucleotides. The system only activates when a cell is placed under severe stress, experiences trauma, or dies.
So when those brittle epithelial cells crack and tear from friction, they literally rupture. And when a cell bursts, it spills its internal contents right into that quiet extracellular space.
And one of the primary molecules it spills is ATP, adenosine triphosphate.
Which we all learned about in biology class as the universal energy currency of the cell. It's what our mitochondria produce to keep us alive.
But the evolutionary brilliance of this system lies in the dual life of ATP. Inside the cell, ATP is vital energy. But outside the cell, ATP is a massive, blaring danger signal.
Because ATP is so precious and highly concentrated internally,
Right.
right? So its sudden presence in the extracellular fluid is just this unambiguous physiological signature that a cell has been violently breached.
Exactly. When ATP floods that extracellular space, it binds to specific receptors on nearby immune cells, which are known as P2 receptors.
And this binding triggers an immediate, aggressive, pro-inflammatory response. It is the molecular equivalent of screaming, "We are under attack, our walls are breached, send the infantry, start the inflammation."
So the immune system responds by flooding the area with macrophages, T cells, and inflammatory cytokines.
Just to clear out cellular debris and neutralize any invading pathogens that might have entered through the microtears.
Right.
But I want to push back on the concept of inflammation for a moment because we often treat the word like a villain. If the intimate tissue has microtears and trauma, shouldn't the immune system be rushing in?
That's a great point.
We want that acute inflammatory response to protect the vulnerable underlying tissue from infection, don't we?
Oh, acute inflammation is highly beneficial and absolutely necessary for survival. You get a cut, the ATP signals danger, the immune cells rush in, do their job, and secure the area.
Right.
But the critical phase of healing relies entirely on an off switch. Once the debris is cleared, that inflammation must be actively suppressed so the tissue can transition from demolition to reconstruction.
Ah, okay. So in chronic conditions like VVA, that off switch is just broken. The tissue is so fragile that it is constantly experiencing new microtrauma.
Yep. The ATP danger signals are stuck on a continuous loop.
So the immune system never receives the signal to stand down, and it just keeps releasing harsh inflammatory chemicals.
And those chemicals begin to degrade the healthy collagen and elastin faster than the body can replace them. It's just a vicious cycle of destruction.
So how does the body normally stop this?
The body's natural braking mechanism for this system relies on adenosine. In a healthy scenario, extracellular ATP is rapidly degraded by specific enzymes in the tissue.
They strip away the phosphate groups until that ATP molecule is converted into adenosine.
Exactly. Adenosine is the heavy-duty brake pedal. While ATP activates P2 receptors to start the fire, adenosine binds to an entirely different set of receptors called P1 receptors.
And the pharmacological data highlights one specific receptor in this family as the ultimate peacekeeper, right? The adenosine A2A receptor.
Yes. The A2A receptor is heavily expressed on the outer membranes of immune cells, specifically macrophages, dendritic cells, T cells, and neutrophils.
So when adenosine binds to the A2A receptor on an active, inflamed immune cell, it delivers a potent biochemical command to stand down.
It signals that the acute emergency is over and forces the immune system to shift its posture from tissue destruction to tissue repair.
Okay, bringing this molecular battleground back to the 54 women with severe vaginal atrophy gives us a really clear picture of their suffering.
Yeah, it really does.
Their epithelial tissue is so thin it tears constantly, releasing just continuous waves of ATP. Their immune system is stuck in a chronic inflammatory loop, chewing up whatever structural matrix is left.
Because they simply do not have enough natural adenosine signaling in that local environment to hit the brakes and overcome the constant ATP alarm bells.
But the polynucleotides introduced via the vaginal ovule, they completely hack this broken system.
They do. The pharmacological papers reveal the exact mechanism here. The polynucleotides, these highly purified DNA fractions, act as direct agonists for the A2A receptor.
And an agonist is a substance that mimics the action of a natural molecule. So the PNs bypass the need for natural adenosine entirely.
Exactly. They bind directly to the A2A receptors in the intimate tissue, essentially manually reaching in and pulling the emergency brake on the local immune response.
Wow. To really understand the power of this agonist effect, we have to look at the intracellular cascade, don't we?
We do. The A2A receptor operates as a G-protein coupled receptor. It sits across the cell membrane, kind of like a complex lock.
So when the polynucleotide binds to the outer portion of that receptor, it forces the entire receptor structure to change shape.
Yep. And that physical shift on the inside of the cell bumps into a specific messenger molecule called the GS protein.
The G's protein acts like a relay runner, traveling along the inner cell membrane until it activates an enzyme called adenylate cyclase.
Right, and that enzyme acts as a cellular factory, instantly triggering a massive increase in a secondary messenger molecule known as cyclic AMP, or CAMP.
And the sheer volume of this CAMP surge is what changes the destiny of the tissue, specifically because of what it blocks.
Exactly. A massive spike in CAMP effectively silences a critical transcription factor known as NFKB.
Okay, I love this part. We can visualize NFKB as a highly reactive, panicked fire chief.
Right, yeah.
The vaginal tissue suffered a microtear, which is essentially a small cellular fire. The fire chief, NFKB, is stuck in a panic loop inside the immune cell.
He keeps aggressively dispatching more and more fire trucks, which represent the inflammatory cells to the site, long after the initial flame has burned out.
And that excessive response becomes the primary problem. All those trucks, all those heavy hoses, and the sheer volume of water start causing massive structural damage to the surrounding neighborhood.
The healthy collagen framework is actively being destroyed by the relentless rescue effort.
But the polynucleotides, by docking into the A2A receptor and spiking that intracellular CAMP here, they act like the mayor of the town, bypassing the chain of command.
The mayor calls the panicked fire chief directly and orders a total stand-down.
NFKB is chemically blocked from issuing any more destructive orders.
And silencing NFKB dramatically alters the chemical profile of the entire cellular environment. The immune cells immediately halt the production of highly toxic pro-inflammatory cytokines.
The pharmacological data tracks a steep drop in specific heavy hitters, right? Tumor necrosis factor alpha or TNF-alpha, interleukin-6, and interleukin-8.
Yes, TNF-alpha in particular is a notorious driver of tissue degradation and pain.
And the cells also cease production of matrix metalloproteinases.
Right, those are localized enzymes whose sole physiological function is to dismantle and chew up the extracellular matrix.
So stopping their production instantly preserves the remaining collagen and elastin fibers in the lamina propria.
The destruction stops.
The mayor called off the heavy fire trucks. Here's where it gets really interesting. The A2A receptor activation doesn't just halt the damage. It forces a profound functional pivot within the immune cells.
It does. The local immune response undergoes a complete polarization. It shifts away from a Th1 pro-inflammatory state and transitions deeply into a Th2 anti-inflammatory pro-healing state.
So as the destructive TNF-alpha plummets, the cells ramp up production of a completely different molecule, interleukin-10 or IL-10.
And IL-10 is the ultimate restorative cytokine. It basically represents the specialized construction crew moving into the neighborhood the moment the fire trucks evacuate.
That's amazing. IL-10 powerfully suppresses any lingering immune reactivity and promotes cellular survival.
Right. With the destructive enzymes shut off, the vaginal lamina propria finally experiences a period of prolonged cellular resilience.
The specialized cells responsible for building structure, called fibroblasts, can finally lay down new collagen and elastin threads without having them immediately dissolved by the inflammatory environment.
Which brings us back to the patients.
Let's close the loop and trace this incredible microscopic cascade all the way back to the clinical reality of the 54 women. We started with subjective, daily misery, severe burning, itching, and tissue that was too fragile for normal intimacy.
And we followed the science down to the molecular level. PNs binding to A2A receptors, the relay of the G's protein, the massive elevation of CAMP,
The silencing of the panicked fire chief NFKB, the steep drop in toxic TNF-alpha, and the surge of healing IL-10.
This complex molecular switch translates directly to the physical relief those women experienced. The resolution of pain is immediate and direct.
Because the intense burning and itching characteristic of VVA are primarily driven by pro-inflammatory cytokines, right?
Exactly. They are constantly irritating and overstimulating the local nerve endings in the thin tissue. When the polynucleotides shut down cytokine production via the A2A receptor, you remove the chemical irritant.
Turn off the cytokines, and you turn off the neurological burning sensation.
Yep.
That explains the pain relief, but the clinical data also highlighted a near 60% improvement in tissue hydration and the healing of superficial bleeding. How does that happen so fast?
Well, the structural healing relies on a synergistic mechanism. First, as the polynucleotides are slowly degraded by natural enzymes in the tissue over time, they release smaller nitrogen precursors, nucleotides, and nucleosides.
And these molecular building blocks possess a profound, persistent viscoelastic effect.
Right. They act as microscopic sponges themselves, physically drawing and holding water molecules within the newly repairing collagen matrix.
The secondary factor is the total rehabilitation of the local environment. The formulation included supporting ingredients like glycerin, which physically softens the rigid mucosa, and lactic acid.
And the lactic acid is the bridge back to baseline health. Because the overwhelming toxic inflammation has been neutralized by the A2A receptor activation, the tissue environment is no longer hostile.
So the natural, healthy flora of the lactobacilli can finally return to the area.
Exactly. They colonize the recovering epithelium and thrive.
And those lactobacilli take over the heavy lifting of maintaining that healthy, acidic physiological pH of 4.0 to 4.5. The clinical investigators noted this specific return to a healthy acidic baseline by the end of the study.
The brittle sponge has been structurally rebuilt.
The tissue finally secured the chemical peace, and quiet required to regenerate its own cellular layers, resulting in a 50% healing rate of those painful microtears.
If we connect this to the bigger picture, we are looking at a fundamental evolution in how medical science approaches tissue atrophy.
Right. We are moving far beyond palliative care here.
Exactly. These polynucleotides do not act as a temporary, inert physical barrier against friction. They are actively infiltrating the cellular communication network to reprogram the localized immune response.
So what does this all mean? It means that treating intimate tissue atrophy, whether the root cause is natural menopause, surgical intervention, or aggressive oncology treatments, isn't just about artificially replacing the moisture that was lost.
It is about utilizing the precision of targeted molecular biology.
Yes. By handing the fragile tissue the exact chemical key, the polynucleotide, to unlock the adenosine A2A receptor, we quiet the localized immune panic.
We stop the body from attacking itself.
Granting the tissue the molecular bandwidth it desperately needs to rebuild its own architecture.
It serves as a flawless model of regenerative medicine. The treatment isn't forcing the body to execute an unnatural foreign process. It is merely providing the highly specific biological signal required to break an unnatural chronic loop of stress.
We started this journey with a deeply distressing, highly common clinical symptom affecting millions of women. We dove into the microscopic, hidden world of purinergic signaling, watched polynucleotides physically dock into A2A receptors,
Trigger a massive CAMP-P response.
silence the relentless NF-κB pathway, and dramatically shift the localized cytokine profile from toxic degradation to active tissue construction.
And that microscopic pivot restored the physical integrity, profound moisture, and vital acidic balance of the tissue, completely changing the daily reality for the women in the clinical trial.
Understanding this precise mechanism gives you a completely new lens through which to view medical treatments. We are moving away from the blunt force of managing a surface symptom and stepping into the era of actively hacking the body's cellular communication networks, which actually leaves us with a massive provocative question.
Because the implications of hacking the A2A receptor extend far beyond intimate health and reproductive medicine.
Right. The vaginal epithelium is fundamentally a mucosal lining, a semi-permeable barrier exposed to the outside world.
And our bodies rely on massive, incredibly complex mucosal linings that frequently suffer from chronic destructive immune loops.
Consider the gastrointestinal tract in patients with inflammatory bowel disease like Crohn's, or the delicate respiratory mucosa in the lungs of patients battling chronic asthma or COPD.
The epithelial barriers in both the gut and the lungs heavily express adenosine A2A receptors precisely because they require constant, rigorous immune surveillance against foreign bacteria and airborne particles.
So if we can effectively utilize polynucleotides to, hack the A2A receptor, successfully silencing inflammation and regenerating mucosal tissue locally without triggering the severe whole-body immune suppression associated with systemic steroids or oral biologics, the potential applications are staggering.
They really are.
Could this localized adenosine hacking revolutionize gastroenterology and pulmonology? Could an oral or inhaled polynucleotide therapy command the immune system in the gut or the lungs to stand down, repairing the structural damage of debilitating inflammatory diseases at the cellular level?
It's a huge possibility for the future of medicine.
It is a fascinating horizon to consider the next time you hear the word inflammation. Until next time, keep diving deep.